Good morning. This is the urinary incontinence and pelvic organ prolapse nice guideline that I've summarized for you. This is to help with your MRCOG revision. I hope you'll find this summary useful. Don't forget to give this video a thumbs up and also subscribe to the channel if you haven't already. So, anyone presenting with symptoms of incontinence, it's important to take a good history and perform a physical examination. Try and categorize the urinary incontinence as either stress, mixed, or urgency. And if there is mixed urinary incontinence, you want to direct treatment towards the predominant symptom. If stress urinary incontinence is predominant in mixed urinary incontinence, discuss benefits of non-surgical management and medicines for overactive bladder before offering surgery. Examination would involve assessing the pelvic floor muscles, which are normally done using digital assessment to assess pelvic floor muscle contraction before use of supervised pelvic floor muscle training for the treatment of urinary incontinence. So offer urine dipstick testing to all these patients. So if they have symptoms of urinary tract infection and are positive for both leukocytes and nitrites, then prescribe a course of antibiotics as well as sending a midstream sample for culture and sensitivity. If there is symptoms of UTI and the urine test is negative for either leukocytes or nitrites, then send midstream urine sample for culture and sensitivity and consider prescribing some antibiotics as well. If there's no symptoms of UTI but it's positive for both leukocytes and nitrites, do not offer antibiotics without the results of midstream urine sample. If there's no symptoms of UTI and if it's negative for either leukocytes or nitrites, then don't send urine sample for culture because UTI is unlikely. Assessing residual volume, so measure post-void residual volume by bladder scan or catheterize in women with symptoms suggestive of voiding dysfunction or recurrent UTIs. Use a bladder scan in preference to catheterization on the grounds of acceptability and lower incidence of adverse events. So bladder diaries, now use these in the initial assessment of women with incontinence or overactive bladder symptoms, minimum of at least 3 days, and all the usual activities like both working and leisure days should be recorded. Urodynamic testing, do not perform this as a first line before primary surgery if stress in urinary incontinence or stress predominant mixed urinary incontinence is diagnosed based on detailed clinical history and demonstrated stress urinary incontinence at examination. History and examination to perform multi-channel filling and voiding cystometry before surgery for stress urinary incontinence who have any of the following. So urge predominant mixed urinary incontinence or urinary incontinence in which the type is unclear. Symptoms suggestive of voiding dysfunction, anterior or apical prolapse, history of previous surgery of stress urinary incontinence. Cystoscopy is not recommended as an initial assessment. Do not use MRI, CT, X-ray for routine assessment. Do not use ultrasound other than assessment of residual urine volume. Indications for referral to a specialist: persisting bladder or urethral pain, palpable bladder on bimanual or abdominal examination after voiding, clinically benign pelvic masses, associated fecal incontinence, suspected neurological disease, symptoms of voiding difficulty, suspected urogenital fistula, previous continence surgery, previous pelvic cancer surgery, previous pelvic radiation therapy. Non-surgical management of urinary incontinence includes lifestyle modification like trial of caffeine reduction with overactive bladder, modified fluid intake, BMI if it's over 30, advice to lose weight, pelvic floor muscle training, trial of supervised pelvic floor muscle training of at least 3 months duration as a first-line treatment for women with stress or mixed urinary incontinence. Pelvic floor muscle training programs should involve at least 8 contractions 3 times a day. Do not use perinometry or pelvic floor electromyography as biofeedback as a routine part of pelvic floor muscle training. Continue an exercise program if pelvic floor muscle training is beneficial. Electrical stimulation is not advised. Behavioral therapies offer bladder training lasting for a minimum of 6 weeks as first-line treatment with urgency or mixed urinary incontinence. Neurostimulation do not offer transcutaneous sacral nerve stimulation or do not offer transcutaneous posterior tibial nerve stimulation for overactive bladder. Do not offer percutaneous posterior tibial nerve stimulation for overactive bladder unless local MDT review and non-surgical management, including overactive bladder medicine treatment, has not worked adequately and the patient does not want botulinum toxin A or percutaneous sacral nerve stimulation. Absorbent pads and things, so do not offer these routinely, offer only as a coping strategy, as an adjunct to ongoing therapy, offer only for long-term management of urinary incontinence in those where after other treatment options have been explored. Review at least once a year using absorbent concomitant products for long-term management of urinary incontinence. Review should include routine assessment of incontinence, assessment of skin integrity, changes to symptoms, comorbidities, lifestyle, mobility, medication, BMI, social environmental factors, alternative treatment options, efficacy of absorbent contaminant products that women are currently using, and the quantities used. So catheters, intermittent or indwelling urethral or suprapubic catheters can be used for persistent urinary retention causing incontinence, symptomatic infections or renal dysfunction, and that cannot be otherwise be corrected. Offer intermittent urethral catheterization with urinary retention to self-catheterize or if there's a carer who can perform the technique. Indications for long-term indwelling catheter with urinary incontinence include chronic urinary retention, skin wounds, pressure ulcers, irritations that are being caused by the urine, distress or disruption caused by bed and clothing changes, if the patient expresses a preference for this form of management. Indwelling catheters, the alternative to long-term urethral catheters. So they can also use suprapubic catheters. It's important to note that there's lower rates of symptomatic UTI, bypassing, and urethral complications with these catheters compared to the indwelling urethral catheters. So medicines for overactive bladder, patients should be informed that there's adverse effects of using anticholinergics like dry mouth and constipation. They may not see substantial benefits until they've taken the medication for at least 4 weeks, and that symptoms may continue to improve slowly over time. Long-term effects of anticholinergic medicines for overactive bladder on cognitive function are uncertain. Offering anticholinergic medications to treat overactive bladder take into account coexisting conditions like poor bladder emptying, cognitive impairment or dementia, current use of medicines that affect total anticholinergic levels, and risk of adverse effects including cognitive impairment. Do not offer women flevoxate, propanthyline, or imipremine to treat urinary incontinence or overactive bladder. Do not offer oxybutynin immediate release to older women who may be at higher risk of a sudden deterioration in their physical mental health. Offer anticholinergic medicine with the lowest cost to treat overactive bladder or mixed urinary incontinence in women. If the first medicine for overactive bladder or mixed urinary is not effective or is not tolerated, then offer another medication, again taking cost into the picture. Offer transdermal overactive bladder treatment to women who are unable to tolerate the oral medicine. Desmopressin can be used to reduce nocturia with urinary incontinence or overactive bladder. Particularly be cautious with cystic fibrosis and avoid in over 65-year-olds with cardiovascular disease or hypertension. Do not use duloxetine as a first-line treatment with patients with predominant stress urinary incontinence. Do not routinely offer duloxetine as a second-line treatment for stress urinary incontinence, although it may be offered as a second line if the patient prefers pharmacological treatment to surgical treatment or are not suitable for surgical treatment. Counsel women about the side effects of duloxetine. Do not offer systemic HRT to treat urinary incontinence. Offer intravaginal estrogen to treat overactive bladder symptoms in postmenopausal women with vaginal atrophy. Reviewing medicines, so a face-to-face appointment or a telephone review is required 4 weeks after starting a new medicine for overactive bladder. If improvement is optimal, continue treatment. If there's no improvement or suboptimal improvement, or it's intolerable because of side effects, then change the dose or try an alternative medicine for overactive bladder and review 4 weeks later. Review before 4 weeks if there's adverse events. Refer overactive bladder patients that have not been successfully treated or unable to tolerate medications to secondary care to consider further treatment. Further face-to-face appointment or telephone review if medicine for overactive bladder or urinary incontinence stops working after the initial successful 4-week review. Review primary care who remain on long-term medicine for overactive bladder or urinary incontinence every 12 months or every 6 months for those over 75. Invasive procedures for overactive bladder. So overactive bladder patients who have not responded to non-surgical management or treatment with medicine, discuss further treatment options. So urodynamic investigation to determine whether detrusor overactivity is causing overactive bladder symptoms, and if detrusor overactivity is causing overactive bladder symptoms, offer an invasive procedure in line with bladder wall injection on botulinum toxin A and urinary diversion, or if there's no detrusor overactivity, seek advice on further management from local MDT and take it from there. Botulinum toxin type A injection. After a local MDT review, offer this injection to women with overactive bladder symptoms caused by detrusor overactivity that's not responded to non-surgical management, including pharmacological treatments. Consider treatment only after MDT review and after local. Discuss benefits and risks with the patient. Is likelihood of complete or partial symptom relief. This process of clean intermittent catheterization required, the risks of this and how long it might be required, risks of adverse effects including increased risk of urinary tract infections. There's not much evidence about how long the injection works for or how well they work in the long term and their long-term risks. Start treatment with botulinum toxin A only if the patient is willing and is able to perform clean intermittent catheterization on a regular basis for as long as needed, or they accept a temporary indwelling catheter if they're unable to perform a clean intermittent catheterization. Use 100 units as initial dose to treat overactive bladder. Offer a face-to-face or a telephone review within 12 weeks of the first treatment to assess response and adverse events. If there is good symptom control, tell the women to continue intermittent catheterization and to report if there is any problems. If there is inadequate relief, then consider increasing subsequent doses of botulinum toxin A to 200 units and review within 12 weeks. If there's no effect, discuss with local MDT. If symptom release has been adequate after injection of 100 units of botulinum toxin A, but has lasted only for less than 6 months, consider increasing subsequent doses of botulinum toxin A to 200 and review within 12 weeks. Do not offer botulinum toxin B to women with overactive bladder. Percutaneous sacral nerve stimulation after local or regional MDT. This treatment may be offered to women with overactive bladder who've not responded to the non-surgical treatment, including medicines. and their symptoms have not responded to botulinum toxin A as well, or they are not prepared to accept the risks of needing catheterization. Discuss the long-term implications of this, including the need for test stimulation and probability of the test success, risk of failure, long-term commitment, need for surgical revision, adverse effects. Tell women how to self-refer for prompt specialist review if symptoms return following a percutaneous sacral nerve stimulation. Restrict augmentation cystoplasty for management of idiopathic detrusor overactivity, that's not responded to non-surgical management and who are willing and able to self-catheterize. Common and serious complications of this include bowel disturbance, metabolic acidosis, mucus production, and or retention in bladder, UTI, urinary retention. Discuss more risk of malignancy occurring in the augmented bladder. Provide lifelong follow-up. Urinary diversion with overactive bladder only when non-surgical management has failed, and if botulinum toxin A, percutaneous sacral nerve stimulation, and augmentation cystoplasty are all inappropriate or unacceptable. Provide lifelong follow-up. Surgical management of stress urinary incontinence. So there is a public concern about the use of mesh procedures. So if a woman is thinking about a surgical procedure, then you should discuss with them the options available, including the different type of anesthesia that will be required, including the different types of implantation of the mesh, any social psychological factors that may affect the women's decision. If non-surgical management for stress and urinary incontinence has failed, and if the woman wishes to think about a surgical procedure, offer the choice of colpus suspension, open or laparoscopic, or autologous rectus facial sling. Also include the option of retropubic mid-urethral mesh sling in the choice. So intramural bulking agents to manage stress urinary incontinence is if alternative surgical procedures are not suitable or acceptable. So explain these are permanent injectable material, repeat injection may be needed, limited evidence that it's less effective than surgical procedures, and the effects do wear off over time. If intramural bulking agent is injected, give written information about the bulking agent. The data of all this should be recorded on a national registry. So mid-urethral mesh sling procedures are permanent implants and complete removal may not be possible. If this is inserted, give the women written information, also information about the implant, the name, the manufacturer, the date of insertion, and implanting surgeon's name and contact details. All this data should also be recorded onto a national registry. When planning a retropubic mid-urethral mesh sling, surgeons should include the manufactured from. It should be. It should be manufactured from type 1 macroporous poly propylene mesh, colored for high visibility and for ease of insertion and revision. Do not offer a transobturator approach unless there are specific clinical circumstances in which the retropubic approach is to be avoided. Do not use top-down retropubic urethral mesh sling approach or sling incision, suburethral short mesh sling insertion, except as part of a clinical trial. Artificial urinary sphincters do not offer this to women unless previous surgery has failed. For women who have had an artificial urinary sphincter inserted, offer post-op follow-up and ensure access to review if needed. Procedures that should not be offered: do not offer women anterior colporrhaphy, needle suspension, paravaginal defect repair, porcine dermis sling, or Marshall Merchetti Kranz procedure. Follow-up after surgery should be done in 6 months. Retropubic mid-urethral sling surgery. Follow-up should include vaginal examination to check for exposure or extrusion of the mesh sling. Providers should ensure that women have had surgery for stress urinary incontinence have got access to further referral if they have recurrent symptoms or suspected complications. Primary surgical procedures for stress urinary incontinence. If this has failed, then seek advice on assessment and management from a regional MDT, or offer the woman advice about managing urinary symptoms if she does not wish to have another surgical procedure, and explain that she can ask for referral if she changes her mind. Assessing pelvic organ prolapse. So in the primary care, history should be taken. Symptoms of prolapse, urinary, bowel, sexual function should all be asked. Examination to check for pelvic mass, other pathology, and document the presence of prolapse. Discuss treatment options and preferences. Refer to secondary care. And specialist evaluation of vaginal prolapse. Perform an examination to assess and record presence and degree of prolapse of anterior, central, and posterior vaginal compartments of the pelvic floor using the POP-Q, which is the pelvic organ prolapse quantification system. Assess activity of the pelvic floor muscles, assess for vaginal atrophy, rule out a pelvic mass or other pathology. Pelvic organ prolapse should use a validated pelvic floor symptom questionnaire to aid assessment. Do not routinely perform imaging to document the presence of vaginal prolapse. If a prolapse is detected by physical examination, symptoms of prolapse that are not explained by findings from physical examination, consider repeating the examination with the women standing or squatting or at a different time. Consider investigating the following symptoms in women with pelvic organ prolapse, things like urinary symptoms that are bothersome, and for which surgical intervention is an option. Symptoms of obstructed defecation or fecal incontinence, pain, symptoms that are not explained by examination findings. Non-surgical management of pelvic organ prolapse take into account the woman's preference, site of prolapse, lifestyle factors, comorbidities, age, desire for childbearing, previous abdominal or pelvic floor surgery, benefits and risks of individual procedures. Lifestyle modifications include giving advice on lifestyle factors with pelvic organ prolapse, include information on losing weight with BMIs over 30, minimizing heavy lifting, preventing or treating constipation, topical estrogens like vaginal estrogen to help with pelvic organ prolapse, and signs of vaginal atrophy. Pelvic floor muscle training is a program of supervised pelvic floor muscle training of at least 16 weeks as first option with symptomatic POP-Q, stage 1 or stage 2 pelvic organ prolapse. Program is beneficial, and if they have found it beneficial, advised to continue pelvic floor muscle training afterwards. Pessaries can be used, and that should be given as an option to patient, but inform them that they may need more than one pessary fitting to get to a suitable pessary. There's different types of pessary. Discuss sexual intercourse with different types of pessaries that are available. Complications include vaginal discharge, bleeding, difficulty removing pessary and pessary expulsion. Explain that pessary may be removed at least once every 6 months to prevent serious pessary complications. Offer women using pessaries an appointment in a pessary clinic every 6 months, or if they're at risk of complications, for example, because of physical or cognitive impairment that might make it difficult for them to manage their ongoing pessary care. Surgical management of pelvic organ prolapse. There's public health concern about mesh procedures because of the complications that have occurred. So offer surgery for pelvic organ prolapse to women whose symptoms have not improved or have declined non-surgical management. Surgical procedure for pelvic organ prolapse should be discussed. Different treatment options should be discussed. Benefits and risks of each procedure should be discussed. Difference between the different types of mesh material, the difference between different types of anesthesia, hospital stay, the role of intra-op prolapse assessment is the most appropriate in deciding which surgical procedure to offer the patient. Do not offer surgery to prevent incontinence in women having surgery for prolapse who do not have incontinence. Explain to women that surgery for anterior prolapse who do not have incontinence there's a risk of developing a post-operative urinary incontinence. Further treatment may be needed. If the woman's chosen procedure for pelvic organ prolapse is not available from the consulting surgeon, then refer to an alternative surgeon. If mesh used in prolapse surgery, explain the type of mesh used and whether or not it's permanent. Ensure details of procedure and subsequent short-term and long-term outcomes all recorded in the national registry. Written information about the implant, including name, manufacture date of insertion, and implanting surgeon's name and contact details. Date on surgical procedure for prolapse recorded in national registry. Surgery for uterine prolapse. So for women with prolapse who have no preference about preserving their uterus, offer choice of vaginal hysterectomy with or without vaginal sacrospinous fixation with sutures, or vaginal sacrospinous hysteropexy with sutures, or Manchester repair. Also include option of sacrohysteropexy with mesh, abdominal or laparoscopic in this choice. If women wish to preserve their uterus, offer vaginal sacrospinous hysteropexy with sutures or Manchester repair, unless they want to have children in the future. Also include the option of sacrohysteropexy with mesh, on use of mesh in prolapse surgery. If synthetic polypropylene mesh is inserted, details of procedure and its subsequent short-term and long-term outcomes should be collected in a national registry. Ensure that the proposed treatment is reviewed by regional MDT if women wishes to have children in the future. So, surgery for walled prolapse offer a choice of vaginal sacrospinous fixation with sutures or sacrocolpopexy, abdominal or laparoscopic with mesh. Surgery for anterior prolapse offer anterior repair without mesh to women with anterior vaginal wall prolapse. Surgery for posterior prolapse offer posterior vaginal repair without mesh for posterior vaginal wall prolapse. Follow-up after surgery, 6 months after surgery, vaginal examination should be done. If mesh is used, check for mesh exposure. So, surgery for women with both stress urinary incontinence and pelvic organ prolapse, it's important to inform the patient that there is uncertainty about the procedure being effective, and stress in urinary incontinence may persist. The risk of complications for surgery being done at the same time and surgery being done separately should also be discussed. Assessing complications associated with mesh. New onset symptoms after mesh surgery for urinary incontinence and pelvic organ prolapse. Evaluate whether these symptoms might be caused by mesh related complication. These symptoms include pain or sensory change in the back, abdomen, vagina, pelvis, leg, groin, or perineum that is either unprovoked or provoked by movement or sexual activity, and either generalized or in the distribution of a specific nerve, such as obturator nerve. Vaginal problems including discharge, bleeding, painful sexual intercourse, or penile trauma or pain in sexual partners. Urinary problems including recurrent infections, incontinence, retention, or difficulty or pain during voiding. Bowel problems including difficulty or pain on defecation, fecal incontinence, rectal bleeding, or passage of mucus. Symptoms of infection either alone or in combination with any of the symptoms above. So refer for suspected mesh-related complications to a urogynecologist, urologist, or colorectal surgeon for specialist assessment. History should be taken at the specialist assessment. Perform vaginal examination to assess whether mesh is palpable, exposed, or extruded. Localized pain and anatomic relationship to the mesh. Consider performing rectal examination. Consider performing a neurological assessment to assess distribution of pain or if present sensory alteration or muscle weakness. For women with a confirmed mesh-related complication or unexplained symptoms after a mesh procedure, refer to a consultant at a regional center specializing in the diagnosis and management of mesh-related complications, or if vaginal exposure of mesh that is smaller than 1 centimeter square and no other symptoms. Responsible consultant should develop an individualized investigation plan with suspected or confirmed mesh-related complications involving other members of the regional MDT. Must ensure that details of any confirmed mesh-related complication are recorded in a national registry and reported to the Medicines and Healthcare Product Regulatory Agency, the MHRA. Managing complications associated with a mesh, so the just general consideration before removing mesh. If mesh procedure is to treat urinary incontinence or pelvic organ prolapse, then think about discussing decision with the patient and with a regional MDT. Explain to the women that there is limited evidence on the benefits of partial or complete removal compared with no mesh removal. Surgery to remove mesh can have significant complications like organ injury, worsening pain, urinary, bowel, and sexual dysfunction. It's not certain that removing the mesh will relieve the symptoms. It might not be possible to remove all of the mesh. Removing only part of the mesh might be just as effective at improving symptoms as removing all of it. Urinary incontinence or prolapse can recur after the mesh has been removed. So, managing vaginal complications. So, discuss non-surgical treatment with topical estrogen cream. If there is a single area of vaginal mesh exposure that is smaller than 1 centimeter square, offer a follow-up appointment within 3 months to assess whether this treatment has been effective. Consider partial or complete surgical removal in women who do not wish to have treatment with topical estrogen, or if the area of the vaginal mesh exposure is 1 centimeter square or larger, or if there is vaginal mesh extrusion, or if there has been no response to non-surgical treatment after 3 months. Offer imaging and further treatment to women who have signs of infection in addition to vaginal mesh exposure or extrusion. Discuss with women who have vaginal complications after mesh sling surgery for stress urinary incontinence that complete removal of the vaginal portion of the mesh sling is associated with greater risk of recurrence of stress in urinary incontinence than partial removal. Partial removal is associated with higher rate of further mesh sling extrusion. Complete removal might not be possible. This is a nice table which summarizes investigations for assessing suspected mesh-related complications. I'll let you read this yourself and go over it at your own free time, but basically it goes through investigation, type of mesh, indications, benefits, and risks. And it just carries on and on and on. I hope you found this summary useful, and if you do, then please don't forget to give this video a thumbs up and subscribe to my channel if you haven't already. Also leave a comment if there's any particular videos that you'd like to watch, and I shall go ahead and try and summarize those for you.